Welcome to this educational program. This module provides an overview of treatment strategies for a troubling condition called chronic prostatitis, or chronic pelvic pain syndrome. It is hoped that you will already have viewed the introductory module, Understanding Chronic Prostatitis, Chronic Pelvic Pain Syndrome, prior to this one. This information is taken from a recent review of the medical literature and attempts to be as comprehensive as possible. However, it may not necessarily reflect the experience of your healthcare provider or the specifics of your situation. This program is strictly informational in nature, and no attempt is made to provide opinion or recommendation. Please feel free to view this presentation as many times as necessary. You may also use the player on your left to repeat slides or to skip through them in any order you wish. To review, prostatitis is a word that describes a spectrum of diseases of the prostate and pelvic area of men. This disease spectrum is very common, affecting over 8 million males every year throughout the world. In fact, up to 1 out of every 2 men may experience prostatitis in his lifetime. Men with prostatitis may present with urinary symptoms, such as frequent, urgent, or painful urination, sexual symptoms, such as a change to ejaculation or blood in the ejaculate, or pain in the pelvic area. Simply put, prostatitis is inflammation or swelling of the prostate. This may be either acute, with a sudden onset, or chronic and slow to develop. Having said this, not all prostatitis cases involve inflammation of the prostate. Doctors have identified 4 distinct prostatitis syndromes, as listed here: acute infectious prostatitis, chronic infectious prostatitis, chronic prostatitis chronic pelvic pain syndrome, and asymptomatic inflammatory prostatitis. These are all defined in the introductory module on prostatitis. Chronic prostatitis, also called chronic pelvic pain syndrome, and now Category 3 prostatitis, is the most common syndrome, and is unfortunately the most troublesome to diagnose and treat. This is the focus of the rest of this module. This is a condition of persistent or reoccurring urinary symptoms and pain, where no bacteria or other germs can be found in the prostate. Patients with this condition may or may not have any evidence of inflammation in the prostate at all. In other words, the process is not always localized to the prostate itself. Because of this, treatment with antibiotics alone does not cure the symptoms. To review, chronic prostatitis chronic pelvic pain syndrome begins with some sort of triggering event which leads to inflammation and nerve injury. Inflammation is the body's response to injury, infection, and other stimuli. Inflammation and nerve injury, in turn, lead to changes in the nervous system, and in time, this leads to an abnormal pain response and to a cycle of chronic pain. Chronic prostatitis chronic pelvic pain syndrome is diagnosed using a combination of a careful medical interview, physical exam, including a digital rectal exam, or DRE, and lab tests. This is all reviewed in detail in the introductory module. A physician's first goal is to rule out other treatable causes of the same symptoms. There are many treatment options available for chronic prostatitis, as shown on this slide. The mainstay of treatment has been the so-called 3 A's: antibiotics, alpha blockers, and anti-inflammatories. The other items listed here are supplemental therapies. We will review all of this in more detail in the next several slides. Ideally, the best treatment of any chronic condition is prevention. Any acute infection should be treated promptly and thoroughly, and this will usually involve the use of appropriate antibiotics for 4 to 6 weeks, possibly with an alpha blocker to prevent another infection. Sexually transmitted diseases, or STDs, are those caused by bacteria or viruses that can be transmitted through sexual contact from one partner to another. For men who are not in a monogamous relationship, condoms should be used, and regular visits to your doctor or an STD clinic are recommended. Furthermore, when possible, a man's partner should be evaluated to be sure that she or he is not a silent carrier of an organism that could be reinfecting him. Finally, injury to the pelvic area should be avoided through the use of appropriate protective equipment, well-designed bicycle seats, etc. Long drives without interruption should be avoided, but when this is not practical, a well-cushioned seat is important. Antibiotics are the key to treatment of acute and chronic bacterial prostatitis. In CP-CPPS, they have had mixed success. If long-standing disease is present and previous antibiotics have been tried, then further antibiotic treatment is not recommended, as only 22 to 33% will respond, which is not different than the response to placebo. If started within 1 month of symptoms, however, and no previous antibiotics have been tried, then the success rate is as high as 75%, and in these cases, treatment is recommended. The most common antimicrobial drugs used are a class called the quinolones, and an older medication called trimethoprim sulfamethoxazole. By far, the two most common prescriptions for this condition in North America are ciprofloxacin, or Cipro, and levofloxacin, or Levaquin. Other quinolone drugs include ofloxacin, or Floxin, norfloxacin, or Noroxin, and gadafloxacin, or Tequin. Trimethoprim sulfamethoxazole comes by several trade names, such as Septra and Bactrim, and many generics are also available. For patients with a sulfa allergy, trimethoprim alone, also called Proloprim, can be prescribed, which does not have the added sulfamethoxazole component. The prostate contains many muscle fibers. These fibers squeeze or grip around the urine channel called the urethra. This squeezing effect blocks the flow of urine out of the bladder, worsens urinary symptoms, and may contribute to prostatitis by creating more turbulent flow of urine through the prostate, which might wash urine up into the ducts of the prostate. Prostate muscle fibers are activated when certain chemicals trigger what are called alpha receptors on the muscle cells. These alpha receptors can be blocked by medications to prevent them from being activated, and this causes the prostate muscle fibers to relax, loosening their grip around the urethra, easing urinary symptoms, and possibly helping to prevent recurrent episodes of prostatitis. For patients with CP-CPPS, more than 6 weeks of treatment with these medications, probably 12 weeks, seems to be necessary to have a beneficial effect, and this is being studied in large clinical trials. There are 4 common alpha blockers as listed here. The so-called selective alpha blockers are able to target the prostate more, with less action on other alpha receptors in other parts of the body. These drugs, alfuzacin, or Zatral, and tamsulosin, which is Flomax or Flomax CR, generally have lesser side effects and can be started and kept at one simple dose. The non-selective drugs, doxazacin, or Cardira, and terazacin, or Hytrin, are more likely to cause some side effects, and typically they have to be started at a lower dose and gradually increased. If you are prescribed one of these medications, it is important to follow the dosage schedule set out by your doctor, and try to get to the maximum dose that you can tolerate. Alpha blockers are safe, and they are well tolerated by patients. Like any medication, however, side effects may be experienced. Some patients may experience sleep disturbances, weakness, or dizziness. The latter, which may result from a drop in blood pressure, is an important effect to watch for if you drive or handle heavy machinery. Stomach problems, fever, and aches may also be experienced, as well as skin irritations, swelling of mucous membranes, and tingling. Some people may develop an irregular heartbeat. A few patients may experience a painful and lasting erection. More commonly, a man's ejaculation may change, whereby there is less fluid that comes out when he has an orgasm or climax. This happens because the opening to the bladder is more relaxed, so during ejaculation, most of the fluid actually goes backwards into the bladder. This is called retrograde ejaculation. All of these effects are reversible if the drug is stopped. Patients should notify their doctor if they are taking blood pressure medications, as some alpha blockers can further lower your blood pressure. Also, some alpha blockers should not be taken if you are taking certain erection medications, such as Levitra. In theory, anti-inflammatories should relieve the inflammation component of CP-CPPS. While good results compared to placebo have not been proven, they are recommended as part of a multidimensional treatment program. There are 2 main classes of anti-inflammatory drugs: the non-steroidal anti-inflammatory drugs, or NSAIDs, and the COX-2 inhibitors. Examples of NSAIDs include ibuprofen, such as Motrin, Advil, and Nuprin, ketorolac, or Toradol, indomethacin, or Indocid, diclofenac, such as Voltaren and Arthrotec, and naproxen, such as Naprosyn or Aleve. Examples of COX-2 inhibitors include celecoxib and valdecoxib, which go by the brand names Celebrex and Bextra, respectively. Elmiron, or Pentosanpolysulfate, is the only oral medication available that works to improve the lining of the bladder for some people. Exactly how it works is not well understood. One theory is that Elmiron helps to restore the bladder wall's protective coating to prevent substances from leaking across into the bladder wall and causing inflammation. It may also decrease inflammation directly. It is not unusual for improvement to take 6 months or more to become apparent on this medication. Hormone therapy is the use of medication or surgery to lower levels of specific types of hormones in the body. A class of drugs called 5-alpha reductase inhibitors, which includes the agents finasteride, marketed as Proscar, and dutasteride, or Avodart, work to lower the levels of the male hormone dihydrotestosterone. These are discussed in detail on the next few slides. The drug Mepartrecin lowers levels of the female hormone estrogen in the prostate. A very small clinical trial suggested a benefit of this drug in patients with CPPS, but larger controlled studies are needed. The male hormone dihydrotestosterone, or DHT, fuels the growth of prostate cells. DHT is a product converted from the primary male hormone testosterone, produced mostly by the testicles and partly by the adrenal glands. 5-alpha reductase inhibitors block the conversion of testosterone to DHT and stop the growth of prostate gland cells. 5-alpha reductase inhibitors can, in fact, actually shrink the physical size of the prostate, and this may improve urine flow out of the bladder through the urethra as it runs through the prostate. These drugs may also take 3 to 6 months or more to achieve their maximum effect, and they do not work on all men who take them. It is possible that these drugs may help alleviate the symptoms of chronic prostatitis in some men, but presently they are only suggested for men who also have an enlarged prostate. Possible side effects of hormone therapy include back or abdominal pain, diarrhea, a lowered sexual desire, erectile dysfunction, hair growth, skin rash, swelling of the lips or breasts, headache, and dizziness. The use of plant extracts, or phytotherapy, has been popular by patients with CPPS. Such agents include quercetin, an antioxidant bioflavonoid found in red wine, grapeseed, green tea, onions, and other foods, and cernilton, which is a pollen extract. These products are generally safe to take and cause few side effects. Saw palmetto, or Serenoa repens, has also been very popular in patients with prostate problems. These products are generally safe to take and cause few side effects. While some small studies have been done and are promising, it is still not clear just how effective they truly are for chronic prostatitis. Properly conducted clinical trials are needed, and some are now underway. Surgery is a last resort for some patients. There are many types of surgical options available, although not all centers and not all doctors will offer each one of these. This slide shows that the choice of surgical treatment progresses from minimally invasive to more aggressive depending on the situation. Minimally invasive techniques, performed through a telescope passed down the urethra called a cystoscope, include microwave thermotherapy, or TUMT, needle ablation, or TUNA, laser vaporization, PVP, and transurethral incision, or TUIP. More aggressive surgeries that can be done through a cystoscope include the laser prostatectomy, properly called a holmium laser enucleation of the prostate, or HOLEP, and the classic operation called a transurethral resection of the prostate, also called a TURP or Tupper. Very, very rarely performed is an open surgical removal of all or part of the prostate. Open surgery and radical transurethral resection of the prostate, while written about, are not recommended treatment options. Surgery should be avoided, in fact, whenever possible, as it may worsen a man's condition. When performed, only therapies with some proven benefit should be attempted, and the least invasive treatment possible should be chosen. To be a candidate for surgical treatment for CPPS, there must be evidence that the prostate or bladder neck is causing obstruction to urine flow, and that all appropriate medications have been tried first. Surgery is an absolute last resort. Furthermore, any active infection must be treated prior to surgery, otherwise major complications can result. Other drugs that can be used to help alleviate the symptoms and effects of long-standing chronic prostatitis, which do not directly treat the underlying problem, include drugs aimed at the nervous system and painkillers. The most common nervous system medications fall within a class called tricyclic antidepressants, especially the drug amitriptyline or Elavil. These drugs have multiple benefits, including reducing sensitivity to bladder filling, relaxing the bladder muscle, relief of chronic pain, improvement in sleep, and improvement in mood. Depending on your situation, you may need to take painkillers only occasionally, or you may need to take them more regularly. This is an important discussion to have with your physician. If your pain is mild, the most commonly used drugs are anti-inflammatories, such as ibuprofen, as we've discussed. The drugs pregabalin, or Lyrica, and gabapentin, or Neurontin, are increasingly being used for certain patients with chronic pain conditions and are an excellent treatment choice. The highest dose that can be tolerated is recommended. Finally, if your pain is very severe, stronger medication, which contains narcotics, may be an option. However, understand that these drugs may not totally relieve all pain, and they can lead to a lesser quality of life and more disability overall. Furthermore, since these types of medications are habit-forming over the long term, you should discuss their use very carefully with your physician. They can also cause severe constipation when taken regularly, so you must take measures to keep your stools loose if you are taking them. Massage of the prostate is recommended by some physicians to drain fluid from the inflamed prostate and thereby relieve pressure and pain. More commonly, prostate massage is done as part of the diagnostic workup in order to recover prostate secretions for lab testing. As for the digital rectal examination, the doctor inserts a finger into the rectum and applies gentle pressure to the prostate in order to release fluid. This procedure can be uncomfortable, but for a few patients it can provide some lasting relief. There is presently no good evidence to recommend routine prostatic massage as a standard treatment option for chronic prostatitis. Pain is registered by the nervous system. For this reason, relieving stimulation of the nerves in the pelvic region can greatly alleviate pain in chronic prostatitis patients. Many patients find relief by something as simple as a hot bath, and in fact, sitz baths, which are warm, hip-deep baths, are recommended by most physicians. When symptoms are bothersome, patients should try to find time to sit in a warm bath for 20 minutes or so, 2 to 3 times per day. During the day, many patients find that cushioned seating, in particular donut-shaped cushions, help with the pain. Muscle relaxants are sometimes also prescribed, as well as physiotherapy of the pelvic floor and acupuncture. To achieve success in managing prostatitis, one should firstly follow the advice of his doctor and consider trying any prescribed therapies. Symptoms can further be managed with some simple lifestyle changes. Eating a balanced diet, low in alcohol and caffeine, and complete with essential vitamins and minerals, and perhaps low in spicy foods, may help ease symptoms. Keeping your weight to a healthy level through good eating habits and regular exercise is also helpful. Finally, as stress can be a contributing factor in chronic prostatitis, stress management techniques and even counseling may be recommended to you. Now that we have discussed the various treatment options that can be used for chronic prostatitis, how does your physician measure the success of a treatment regimen? For bacterial prostatitis, a test of urine and prostate secretions should be negative. That is, bacteria are no longer detectable. This would indicate that the antibiotics have worked. For patients suffering from chronic prostatitis chronic pelvic pain syndrome, the goal of treatment is to relieve symptoms and improve quality of life. This can be measured by an improvement in symptom scores of any of the standard questionnaires that physicians use, with the NIH Chronic Prostatitis Symptom Index being the most widely used and accepted one. Ultimately, you, the patient, will determine if your treatment program has been successful. Research continues into studying the cause of CPPS and into development of new classes of drugs for treatment of all types of prostatitis. Current treatments and their combinations will continue to be properly assessed in large-scale, controlled clinical trials while new treatments are developed. What does the future hold for chronic prostatitis treatment? Researchers are addressing two issues with regards to antibiotic treatment of prostatitis. A common drawback of the overuse of antibiotics is the development of resistant bacteria. Thus, research is concentrating on developing new antibiotics to combat antibiotic-resistant prostatitis. The second issue is the presence of bacteria trapped in calcium inclusions within the prostate. This phenomenon is believed to be more common in older chronic prostatitis patients. These so-called nanobacteria are not targeted by traditional antibiotic treatments. However, a new therapy called COMET or COMET has been derived. COMET is a combination of tetracycline antibiotic and a mix of vitamins, minerals, and EDTA, which allow the antibiotic to penetrate the calcium inclusions and target the nanobacteria. Finally, the Chronic Prostatitis Collaborative Research Network is researching better means of managing prostatitis. With ongoing efforts from the medical community and feedback from patients like you, optimal treatment of chronic prostatitis are within our grasp. In summary, chronic prostatitis can best be treated when detected early. In these cases, treatment with antibiotics and drugs called alpha blockers can be effective. When the condition is more long-standing, the primary goal is to relieve symptoms. This can be accomplished through a so-called multimodal approach that is individualized to each patient and will involve a combination of conservative measures such as lifestyle changes and medications, which may include one or more of several options as deemed appropriate for your situation by your doctor. Types of medications used include antibiotics, alpha blockers, anti-inflammatories, hormone therapy drugs, plant extracts, and pain medications. Surgical interventions, which can be minimally invasive to more aggressive, are a very last resort for very select patients only. Treatment progresses from the simplest effective approach to a more complex or aggressive approach as necessary. Remember that there are things that you can do on your own to relieve the symptoms and impact of chronic prostatitis, chronic pelvic pain syndrome. These resources on the internet may help you find further information or support about your condition. These current references were also used to assist in the preparation of this module. All of these are available through your local medical library or the internet if you are interested in more detailed reading on this subject. We sincerely hope that this module has furthered your understanding of treatment for chronic prostatitis, chronic pelvic pain syndrome. We wish you the best for the future, and thank you once again for viewing this educational program.